It's a pleasure to introduce Dr. Cindy Yeung, who is a postdoctoral research fellow in the clinical pharmacology and toxicology in the Hospital for Sick Children, Toronto, Canada. Her overarching aim is to use pharmacokinetics to translate mathematical models to significantly advance our knowledge in drug PK in pediatrics. Her focus is to reduce adverse drug reactions in therapeutic orphan populations who are normally neglected in drug development process. Today, she's presenting in a PBPK model to estimate cannabinoids, cannabidiols in breastfeeding infants. Thank you.
Can you hear me? Yes. Thanks so much for that introduction. I'm really impressed that you had no script and you pretty much memorized my bio. So awesome. Happy to be here today, and thanks for the organizers for inviting me. I was excited to hear this morning that we have 3 talks on lactation and PBPK modeling. That's so exciting when you've done 4 years of a PhD on this topic, and then it's becoming more widespread and studied. So today I'm going to be talking about PBPK modeling to estimate cannabidiol, or CBD, exposure in breastfeeding infants. CBD is a cannabinoid of cannabis. It is the non-psychoactive component versus you might be familiar more with THC. CBD is a lot more understudied, so that's what we're going to be talking about today. This work was in collaboration with the University of California, San Diego. I was fortunate enough to visit there for 3 months and do lots of projects with them. So this is the project here. And this is supposed to work, but I don't think it is. Okay, I want us to first think about this exercise. So imagine you are a detective on a very difficult case, and you can choose your favorite detective. It could be Sherlock Holmes, for example. But it's the hardest case yet. In fact, there is a culprit loose, but there's no information really available for you. But the fact is you have to make a decision because the culprit is at large, and you need to figure out the mystery. Now, that scenario actually isn't so different from when mothers are breastfeeding and taking medications. I have an example here of a mother who's taking CBD, for example, for chronic pain, MS, migraines. And so as a clinician, you might look into different resources to advise this mother. So you go into LactMed, which is a database of over 2,000 drugs with available evidence on it in breastfeeding scenarios. And you see there that it's deemed that it is present in breast milk. So at least we know that it's found in there. But the idea, the relationship of the maternal dose to what's found in breast milk is highly variable. As well as there's no relevant information about infant plasma data. So we don't know anything about exposure to infants. And finally, we don't know the effects in infants either. So we might look to other authoritative resources like the American Academy of Pediatrics, and we read what they say, and they said that, again, there's not much information out there, but from what we do know, maternal marijuana use while breastfeeding is highly discouraged. We also look to the FDA, and they also mentioned that there's not much information out there, but they also discourage it based on what we know. Now, what are we basing this evidence on? Mainly animal studies, and those 2 studies I point out there by Tens and Astley and Little in the 1980s and early 90s. And what they essentially said in a nutshell is they conducted small observational studies. For example, 258 mothers were included. Some were taking marijuana, some weren't. But then they looked at the outcomes in the infants and there was potential for neurological or neurodevelopmental delay. Some issues with these studies include that the infants are only looked at 1 month of age. The mothers were only taking it during the 3rd trimester, and there could have been some other medications or alcohol being consumed. So lots of uncertainties there. So with that information, I ask you this thought exercise. How would you advise this mother-infant pair, given what I've just told you? Now look at from one end of the spectrum, do not stop taking CBD and do not breastfeed, to unsure, which I'm sure most of you are, and over to continue taking CBD and breastfeed. So just take a couple of seconds to think about this answer in your head. Okay. So for today's agenda, I'm going to elaborate a little bit more on this issue at hand. And with that issue, I'm also going to propose a potential solution. And that is this upper area under the curve ratio, or the UAR, that we created throughout my PhD. I also talk about the opportunity with UC San Diego for using their real-world data with breast milk samples. And then we use that in combination with pediatric PBPK modeling to determine the UAR. And then we'll have some discussion, future directions, and conclusion. So a little bit of background. Breastfeeding and maternal medication. So as I mentioned, the American Academy of Pediatrics, they recommend that infants are to be breastfed for the 6 months postpartum exclusively. Why? Because there's many benefits of breast milk. So first, there's benefits to the mother and the infant, for example, and decreasing the risk of necrotizing enterocolitis. And it also promotes different benefits like cognition in the newborn. And so it becomes a no-brainer that mothers tend to breastfeed. However, as we've heard earlier, that there's complications that arise. Although more than 90% of mothers start breastfeeding, almost 80% are taking medications. And because of this uncertainty of whether there's any risk to the breastfeeding infant from the lack of information, lack of drug development studies, many mothers tend to either discontinue their medication or discontinue their breastfeeding. So in light of this uncertainty, what kinds of resources do we have? So in terms of resources, Alamika mentioned one of them, which was the relative infant dose, or the RID. And that's broken down in a bit more detail here. So we have on the numerator, the milk concentration that the infant would consume from the breast milk, as well as a standard volume of milk intake that they'd receive. People say 150 as a pretty arbitrary number. And you divide that value by a maternal dose. That is typically the dose that the mom receives for therapeutic effect. So you really don't want that numerator and denominator to be similar, because infants are going to get therapeutic levels. And as Almika said, some say 10%, some say 5%, but this number hasn't really been established. There's also resources below, such as LactMed I mentioned, that kind of help you with the information and data out there. And to really just drive us all home, these current methods, including the RID, don't really count for 3 things. So one, the anatomy and the physiology of the breastfeeding infant. So even that equation up there, the only thing that really talks about for the infant is that volume of milk intake. And I just mentioned it's pretty arbitrary. Second, age-dependent factors. So even the fact that across infant ages, you might have different volume of milk intakes. So for example, a 2-week-old might be consuming more breast milk per weight basis than a 2-day-old. And third, the variability in the infant and the maternal population. So the idea that maybe moms might have a pharmacogenotype that may lead to more concentration or high concentration in breast milk, and therefore maybe higher exposure in breastfeeding infants. So to fill in this gap, we used PBPK modeling and also leveraged that in order to develop this new metric called the UAR. Now, before I dive into the UAR, I just wanted to give a little bit more of a background again about the whole process with PBPK modeling in lactation. So on the left-hand side, we have our typical workflow. We start off with the regular inputs, physical chemical properties, ADME, and the anatomy and physiology of the individual. We make the model of in adults first in a data-rich environment, and then create populations for adults by adding variability, and then finally scaling to infants with growth and maturation factors. And so with this, after the scaling, we end up with a virtual breastfeeding population. And so that's pretty neat. We can give them estimated doses from breast milk and then simulate out what their exposures might be. Now, this process is not novel. We just heard it before too. There's a couple of drugs out there that have described this process of using PBPK in lactation, and some have led to changes in labeling, for example, with codeine and Tylenol T3. So it's that powerful. Now let's talk about the UAR. So the UAR, the upper AUC ratio, is simply after we get that virtual breastfeeding population. Let's say we have 100 of those infants. We also simulate out their AUCs on that drug. And so what we do is we take the 95th percentile of those AUCs. So that's the infants who are most at risk. And that's our numerator. And we divide that by the median therapeutic AUC, which can be from adults or children that have had an indication. So again, similar to the RD, where you don't want those numbers to be close, but this time we're looking at those who are most at risk, those outliers, 95th percentile. And to look that a little bit more visually here at the bottom, we see that if we have AUC on the x-axis, that the AUCs that were simulated, and on the y-axis, the frequency, in blue, we have the breastfeeding infants AUC simulated out, and in red, we have, let's say, the maternal AUC simulated out. And the dashed blue line is the 95th percentile, and the red dashed line is the median percentile. And what we don't want to happen is to have those too close, the 95th and the 50th. That would make the UAR go up. And so we might repeat this exercise for different age groups, let's say 2 to 4 month olds on the right-hand side, and the AUCs are a bit different for these breastfeeding infants. And so the dashed lines get further apart and maybe your risk decreases. And so the UAR number might decrease as well. So let's get into the CBD work here after all that background and introduction. So the research question is, among breastfeeding mothers taking CBD based on real-world use, what is the predicted exposure and its associated variability in breastfed infants? So starting from the very left, we looked at CBD concentrations in breast milk. This was voluntary samples, donated milk samples from mothers as part of UC San Diego's Mommy's Milk program, or the Human Milk Biorepository. So we were able to collaborate and partner with them and get some milk samples of CBD. We use that information to inform two things. One, the infant dose that they might receive through breast milk, and two, defining different subgroups. So we also got information from Mommy's Milk, the frequency of CBD or CBD-containing products use, the administration type, the time after dose. And so we might make arguments that maybe if they're on a specific administration type, let's say an edible, they might have a higher concentration in breast milk and therefore maybe in exposure as well. The second part was we had an adult CBD PBK model developed in a previous publication that we did, partnering with the University of North Carolina, and we're going to scale that to infants, our breastfeeding infants. And third, we're going to use that to predict CBD exposures in the breastfed infants, and then also get at that UAR metric. So in terms of methods, let's start off with dose. And the dose equation is shown here. It's actually quite simple. The infant daily dose is the CBD concentrations measured in our voluntary samples. And if you take that and multiply that by a weight normalized volume of milk intake, you get a daily infant dose. And so if you work out those units and cancel them out, you get the nanogram per kilogram. So I want to first focus on the CBD concentrations. How did we attain that from the data set that we were given? So looking at the data set, we viewed it in two ways. So that's data set 1 and 2. The first data set was looking at all the concentrations of CBD we got in the breast milk. So it's about 200 concentrations or so. We would use those doses to simulate, those concentrations to simulate the doses for the infants. This data set 2 looked at more of defining those subgroups that I mentioned. In order to do that, we did a couple of things. One is we had to limit the sample to only samples with the one single administration type. So if a mom was taking like a blunt and an edible, we excluded them, like that sample, or any other combination. And we went more cleanly and went with, if they were just taking a blunt, that's the data we got for that sample, or taking just the edible, that's just a sample. Because one, the sample size for those combined administration types were too low to make any conclusions. And two, we wanted to make this the cleanest kind of analysis as possible for conclusions. The other part for the potential subgroups is, so I mentioned administration type was a potential subgroup, as well as time after the last dose, as well as dose frequency. So increase of dose and also the frequency of, let's say, using a pipe. I learned a lot of different administration types throughout the study, by the way. Okay, so we use that knowledge to create a linear regression model, and then we use the log concentration as the outcome, and then we just saw which of those covariates might be influential or predictors. The other point I just want to raise really quickly is we had a lot of BLQ values. We had to handle them in some way. And for data set 2, we actually considered with and without BLQ values. The reason for that is, you'll see later, but it tended to create poor residuals in the model, and it was hard to detect any pattern with that. So let's look into the next element of our dose calculation, and that's looking at the weight normalized milk intake. How do we determine that? Actually, Alamika already mentioned this model here, but it's from our publication, a literature review based on the breast milk intake that infants might receive across different infant ages. And that's shown here on the x-axis of different ages, and on the y-axis is those weight normalized milk intake volumes. And essentially, these were studies that weighed an infant diaper before and after breastfeeding, which was pretty neat and cool way to measure intake. So the equation here on the right-hand side shows the nonlinear equation that described this. Dark black line is the mean. And then we also expressed variability, and just highlighting a couple things like 2 weeks tended to be the highest milk intake volume at around 153 mg per kg per day. Looking to the next step, we got concentration, we got the milk intake volumes. Now let's get the dose that we needed for the simulations. So again, looking at data set 1, we used all concentrations in breast milk. What we did there is random sampling with replacement. So that is like taking a huge bag, imagine filling it with marbles, and each marble is the 200 milk samples, and we would pull out one marble, which is one concentration measurement, and then we use it for the dose, and then we put it back in, and we repeat this process. The second part for data set 2 is looking at those significant subgroups. Again, we only looked at the non-BLQ values from the start. They tended to have a log normal distribution with the mean and variance from the log concentrations. But we took them out for essentially looking at differences between the subgroups. But we actually needed them back in when we did the dose simulations, because it doesn't make sense to throw out all the BLQ values. It's important to know that they are below 0.1 nanogram per milliliter, for example. So we added them back in using a logistic regression model that helped us predict the BLQ values, where the longer the time after dose, the more likely to have BLQ values. And in terms of the PBK model development and evaluation, so on the very left, we start off with our adult CBD PBK model that I mentioned was published. It showed adequate accuracy and precision. And I'm also just showing a snippet of the oral pop population model here at the bottom. And then we scaled to pediatrics, and we were able to evaluate in a literature published study of 4 to 11-year-olds who were taking CBD for epilepsy as a solution. With that, we were able to scale up to 200 virtual breastfeeding infants per age groups from 0 to 1 year old, and we binned them knowing that there's some differences because of age. And then we gave them the CBD solution in breast milk using those previously simulated doses that I mentioned. We also repeated this exercise not only for all those sample concentrations, the 200, but also for each subgroup. And so finally, we were able to get the AUCs from 0 to 24 hours for each of these infants, and then we were able to attain the UAR. Now, these are the results. And this is a pretty big slide, so I'm going to take some time to go over it. Let's first look at the data in general. On the left-hand side is the CBD concentrations in milk on a log scale. And on the x-axis, we have time after dose. And I've presented the BLQ values here. Essentially, as I mentioned, there were 200 samples that were ascertained from 181 unique mothers. And BLQ values were about 42% of the data. And we look over to the middle and the right plots there, box plots, and we look at the administration types, joint blunt, edible, oil, pipe, other not reported. And then on the right-hand side, we also have our dose frequency, which I separate into low, medium, and high. And so just pointing out here that, again, I'm not showing any BLQ values there, but we do tend to see some sort of potential relationship, especially in the administration types. Another thing to note is I mentioned that we only used one administration type for that sample. So this led to around 142 samples that are shown in these plots on the right. So we used backwards stepwise elimination to figure out which of the subgroups were significant. So we looked at the time after dose, and we looked at the administration types, and we also looked at the dose frequency and interactions, meaning that, let's say, if dose frequency had an interaction with administration type, then maybe only a joint is significant if it was at a high frequency of use, for example. That's sort of what the thought is. And at the end of the day, we did see statistically that joint blunt tended to have lower concentrations in breast milk than oil and pipe. So those were the focuses of the subgroup analyses. So looking at more results, we're now looking at the CBD concentrations in milk and the different dose distributions. So on the very top rows, we see the concentrations that were used. For the full data set, we used the sampling across the 200. That was that sampling with replacement. And then the joint blunt or edible, that was log normally distributed with that geometric mean and SD, so a log normal distribution. Same with the oil and pipe. Again, we separated those two out because those are significant in our subgroup analysis. And then looking at the doses, which are in the 3 rows below, which showed that some distributions there that were simulated from using the concentrations and the milk volumes that were randomly selected for these infants based on their age. One note there is that, again, we used the BLQ concentrations were simulated with time after dose being significant. Other results I just want to show really briefly when we did compare our pediatric PBK model results to those children taking CBD age 4 to 11 years old. We did find a pretty accurate predictions for AUC. And this plot here pretty much summarizes the main results I want to show, which is looking at CBD PBK model predicted daily steady state AUCs of children compared to the breastfeeding infants. So on the very left here, we see from 4 to 11-year-olds, That was the exposure that was observed in the literature. And on the y-axis is the predicted plasma AUCs. And then the next block over are the exposures that were predicted for infants using all the samples I mentioned, all 200. So the age groups were 0 to 7 days, 7 to 14, and so forth, you can see there. And then the next block over was just the joint edible. And then the block over that is the oil and pipe. So really the take home here is you can see that our simulations show that the exposures that breastfeeding infants might get, across the board are much lower than what children can therapeutically get on the left-hand side here. We do see the oil and pipe visually that perhaps they are receiving a little bit higher exposures, which was expected from our subgroup analysis. So to talk about a bit about the clinical implications and strength. So just the idea that, again, oil and pipe tended to have higher concentrations than joint blunt or edible. So maybe that should be thought about or discussed. The idea that the longer the time after dose, the greater likelihood of BLQ value. So perhaps one day that could help inform maybe after a certain time after dose, then the concentrations are going to be very, very low in breast milk. The UAR was also considered very low, especially compared to other drugs that we looked at, like lamotrigine, the anticonvulsant, where it had a UAR of 0.18 to 44 on some of those age groups. Versus here, I think the UAR was like 0.00033, something like that. And some of the strengths is we use limited dose data, and we were able to provide some new knowledge in the space in terms of exposure, moving away from dose. We used a PBPK model that performed well in children and adults, and we addressed some uncertainty in bioavailability as well. Some limitations and future directions. There was a small sample size per subgroup, so it was kind of difficult to look at dose frequency, for example. This was all self-report, so you can imagine, I don't even know, talking about frequency of use and then recording it. Mothers had 2 weeks to write that down, so it could be hard. And then the lack of plasma data for validation from infants, that would have been nice too. And then future directions is maybe looking into THC. I know Mehta Gandhi has research on that. Also, mommy's milk has a lot of THC data as well measured, so maybe that would be of interest. I know they're much higher in concentration than CBD, and it has that psychoactive effect. And also, what's interesting is the San Diego group is also doing neurodevelopmental tests on these infants. So that would be great, like moving from dose to exposure more to response and seeing if there's actually an effect. So these are the finishing slides, and it's going back to this thought exercise here. And I want you to think about this again. Given what I've shown you in this presentation now, would your opinion change or would it stay the same? Would you say to advising a mother-infant pair to stop taking CBD, do not breastfeed, you're still unsure, or continue taking CBD and breastfeed? Some references. And then a large thank you to the Waterloo team, where I did my PhD, CHR grant funding in Canada for my own scholarship, and then also the project grant that supported this work, as well as UC San Diego, and my supervisor for the PhD, Dr. Andrea Edgington, our various San Diego collaborators with Mommy's Milk, and our Sick Kids collaborator with the CHR grant. So thanks for your attention, and looking forward to questions.
Really nice talk. I'm curious about, there is an FDA-approved CBD, Epidiolex. Is that the oil that you're referring to here? It is. Okay. So then I guess in your results, you're showing that the concentrations for the oil are kind of similar to what mothers are being exposed to with the smoked. Is that a correct interpretation?
It's more so, if you think about the comparison of what breastfeeding infants might take, and like a therapeutic concentration and exposure. Instead of using like an adult exposure, instead of using a maternal one, we ended up using the children one because it was more comparable, the closest thing we have. We wouldn't want those exposures to be similar. But it's not so much that the exposures in the children might be the same as what moms might be getting, but it is like one kind of comparison that we can use to say that it's FDA approved and it is at therapeutic indications. But it would be interesting, to get that information about moms, what concentrations they're taking. You can already see that this data is really difficult to work with. Like the dose frequency wasn't as you expect. Not everyone got it from the same dispensary, the medication or the drug. So like we wouldn't have like the milligrams of a blunt. We just have number of puffs, which is difficult to work with. Yeah.
Well, that was a lousy presentation. No, I just wanted to say that because everybody's been saying how great the presentations are, and your
It's good to
presentation was,
have, people against,
yeah, your presentation was really wonderful. I wanted to ask about the frequency of breastfeeding. Actually, the mother, how much milk comes out of the breast and over time, because time from last dose is also probably affected by whether they're expressing their milk out of their breasts and other things. Do you have was that in your model at all? And do you have any comments and thoughts about that?
Good question. So a bit on dose frequency. In that literature review I showed with the different volume of milk intake over time, we also looked at the frequency of breastfeeding in the literature and found that it tends to range from 6 feeds a day to up to like 11 and 12 feeds a day. And not really a relationship across different ages, but there was that kind of variability there. The reason why we didn't include that into the model is in stepping back and thinking about what frequency of intake is used for, it's mainly used for looking at Cmax to say that there might be some accumulation of that, dose over time from frequent feeding over the days. So we were more interested in looking at exposure, which is not related to Cmax. And so the total exposure that an infant might be getting through breast milk. And so it kind of simplified the problem there. We also thought if we were to compare exposures to exposures, that made sense. But comparing for this drug, Cmax of the breastfeeding infants to Cmax of the children taking Epidiolex or adults will likely not be comparable because, as you saw, they're receiving doses so low. So again, like Cmax wasn't our focus, and therefore we didn't look at frequency of breastfeeding. And yeah, that was essentially the gist of it.
Let me preface this by saying that I grew up in Colorado, which was the first state to legalize marijuana. I wanted to follow up on Sam's question. When you said oil, were you referring to what was given to the 4 to 11-year-olds that she was comparing it to? Or were you referring to the point on the bar graph that said pipe/oil? So is that more like the concentrate that you like bong out of? Like, were you referring to a bong?
So sorry, maybe I should go to the slide. There's so many terminologies and things. Okay. So it's not this slide, right?
No.
Okay.
Yeah, it is. Go back. Sorry.
So
Yeah.
this.
Pee, oil, or pipe.
Okay, oil or pipe. Yes, the moms were taking. So on the very right-hand side is what the moms were taking.
Right.
They were taking, yeah, a bong or pipe.
Oh, it's a bong. Okay.
Yeah.
So I can clarify a little bit coming from Utah. We are the essential oil capital of the world. So the oil refers to CBD essential oil. A lot of it's a huge thing. Moms they come in little containers and they take a drop or two for various reasons. So it's a huge market. And the one of the companies based out of Utah, it's called Yeung Living, and they are kind of like world leaders in CBD oil. No. They just take like they might have used it as a bong. I don't know, but Oil is basically, it's like highly concentrated CBD, 99.6, 99.7% CBD pure extract. They don't market it as a therapeutic because they cannot. They market it as a cosmetic agent. They market it as an humectant or some kind of like moisturizer. That's how they market it. But a lot of women take it for therapeutic purposes.
Thanks for the clarification. And just to clarify again, so on the very right-hand side, like those subgroups were the administrations that the mums were taking and then gets into the breast milk. On the very left-hand side here, like that, the 4 to 11 years old were the drops of oil. And so from what the moms were taking, yeah, they could have been taking from a pipe or from this oil drops. And so it's such a heterogeneous data set too. So there could be bongs in there as well. Were you thinking more of the lines of like maybe that would change concentrations or anything? Okay, yeah.
Question. I agree with your comment on, but what would you use as a pharmacodynamic endpoint, or what's the outcome? You know, is it like, you know, certain biomarker? Is it like learning disabilities? Is it functionality? So how would you approach that?
Yeah, good question. So what UC San Diego is looking at is the Bailey's developmental score. So they're actually going to do one-to-one face-to-face testing and doing those like neurodevelopmental delay tests with a specific score and then seeing if that's related. It's hard though, because that's something that might happen at 2 years old, you know, 3 or 4. It's hard to determine. It has to be like a longitudinal type of study. But there doesn't seem to be, at least from what I know, thinking about immediate biomarkers that can kind of give us a quicker signal. Yeah.
Yeah. Do you think there's an opportunity to put this in the context of an overall risk landscape? Let's say if somebody took like, you know, coca, you know, let's say in Peru, or like, you know, somebody, you know, smoked like morphine in, you know, Afghanistan, and what we learn from that, and, you know, how bad is it in, you know, how good or how bad is it in context of, you know, what's out there?
Are you asking like, what if we extended this to look at morphine as well, like other kinds of
Yeah,
drugs?
so what's the relative risk? You know, what's the relative harm that we are doing here?
The relative harm of
Like infants being exposed to CBD
of CBD.
relative to, let's say, other
Okay.
psychostimulants.
That would definitely need to be studied, I think. We could repeat this exercise with morphine and other kinds of drugs, opioids, and then see what the UAR is, what the exposure is from PBK modeling. I think that would be an interesting exercise. Yeah.
Yeah, maybe, you know, good research project there.
Yeah, I think so. And fentanyl, like lots out there. So much work that can be done in this space. As I mentioned, the only drugs we did compare it was with lamotrigine, which tended to have a high UAR, and ezetimibe we also looked at. And the group is also doing much more.
I think we just have time for one last question, and this one's online from a trainee. You mentioned sample size is a limitation. Roughly, what's the number of needed samples or sample size to prompt an official guidance on CBD and breastfeeding, taking into account variability of exposure? And Elamika, you may feel free to weigh in as I call a friend on this question.
Yeah, I think that's a really hard question. I do defer to Almika about in relation to the FDA, what's appropriate. But in terms of statistically, like the sample sizes for some of those subgroups, when looked at, for example, dose frequency, they were just so low. Some of them had in the low category only like 5 individuals and maybe, or sorry, 5 samples, and maybe the medium and large were only a few as well. So from that, we just saw that it wasn't large enough to make any conclusive statement based on that. Overall, though, with the 200 samples, we believe that we reached pretty good number for making an overall conclusion. So I can talk about that, but I'm not sure, Elamika, if you're on the call, if you want to comment on the rest.
I was just going to say, unfortunately, we don't have a particular standard right now on what's enough. We're almost always just scrambling to make sense of the limited data we have, just because the amount of information you have in this case is much more than we generally get in lactation realms. So thanks for sharing this. Just visually, it does sort of bring sort of a point. I think we're sort of stuck with, oh, okay, we report the RID and we report this type of numbers, but how does that truly translate? So having this continued discussions on the best way to translate some of this information is useful.
Thank you. Yeah, and we hope to share this with clinicians as well as a visual aid. So that's it from my presentation. Thank you, everyone.
Thank you, Dr. Yeung. And I must say, I disagree with Dr. Bergstrom, even though I might get into trouble. That was a great presentation. Thank you so much. It's my pleasure again to introduce Dr.